Good morning, everybody. I'm Regina, professor of child and adolescent psychiatry and chief of faculty development at the University of Florida in Gainesville. And it's really an honor and a pleasure to be here. I want to thank Marie McPherson and Sabrina Singh from the Florida Center for Behavioral Health Improvements and Solutions for organizing these regular guideline updates. They really represent an invaluable resource for the mental health care of Florida youth, and it's exciting that we have the chance to be together today. Briefly reviewing any potential conflicts of interest. I don't have any direct financial conflicts. There is Psychiatry Department contracts with the Department of Children and Families for pre-consent reviews for children in foster care. I have service in membership roles in several organizations, including our local advocacy group, NAMI. And to ground us, what we're doing today is we're revising the 2018-2019 guidance. That's exciting that we're going to be having new ones available. We are building on our existing framework and previous review cycles, and therefore reviewing new findings since the last meeting in 2018. And then our work is going to be to discuss and revise the guidelines for under 6 years and for the 6 to 17-year-olds, and also look at the corresponding medication lists. What I'll be doing over the next 30 minutes is I will go over any new guidelines or Cochrane reviews that have been identified since 2018. I will provide you with an abbreviated literature review for that time period, and you will see it identified a couple relevant trials for the preschoolers and 19 for the 6 to 17 years of age, touch briefly on some other interventions, and then also make some suggestions to jumpstart our discussion about updating the guidelines. So that's what's ahead, and we'll be fast because there's a fair bit to pack in. This is just a brief visual reminder of the evidence review that our current guidelines are informed by, and for those of you who have been with it for several cycles, you remember the review materials that informed us. And for situating us for the current evidence review, this is the time period that we're covering and that I will fill in the next brief time period. So jumping right to the 2019 AAP guidelines, there were no dramatic changes to previous recommendations. They produced 7 key action statements. 6 are considered strong recommendations based on grade A/B evidence, and the interventions are considered by age. So we have for the preschoolers, again, the recommendation to prescribe evidence-based parent training and behavior management and or classroom interventions first, and may be considering methylphenidate. For the school-age children 6 to 11, FDA-approved ADHD medications and or evidence-based behavior therapy. It's emphasized that educational interventions and supports are necessary. And then for the adolescents, again, FDA-approved medications with assent may prescribe evidence-based behavior therapy, and the emphasis again on education interventions and supports. There is a more explicit attention paid to titrating medication doses to achieve maximum benefit at minimal side effects. In the document, they also identified numerous systemic barriers that may restrict or hamper pediatric clinicians to adopt the recommendations. So there are some accompanying additional documents, but those wouldn't be relevant for our review today. Another relevant document was produced by the World Federation of ADHD, an international consensus statement producing 208 evidence-based conclusions or nuggets, we might say, about the disorder. The goal here wasn't so much to produce treatment guidelines as it was to curate findings with strong evidence base. They conducted meta-analyses of large studies and also of sizable meta-analyses, had requirements like they needed to assess publication bias, and they also excluded studies with waitlist or usual care controls. So it's a very streamlined set of conclusions that were approved by 80 authors from 27 countries and 6 continents, and they produced these 208 items of which items 148 to 194 address medications, and items 195 to 208 address non-medication treatments for ADHD. To give you a sense, in the medication section, they're addressing effects on symptoms, also very interesting results of naturalistic studies, assessment of adverse effects and findings regarding misuse and diversion. None of them render for us any particular new insights with implications for the guideline revision, but they're a great resource. They refer briefly to supplements and diets, and I'll touch on that later. So that brings us to our review of clinical trials for the under 6-year-olds. When we met 4 years ago, there was nothing there. This time, of 50 records identified and screened, I thought 11 were suitable for full text review, and I'm presenting results of 2 studies. You can see reasons for excluding or discarding, and the slides will be available for you to look at this in more detail if you wish. The 2 studies reviewed, one of them is the lisdexamfetamine study, or the Vyvanse study, which was a dose optimization study. Smaller size, only 24 subjects, ages 4 to 5, and lasting 8 weeks, looking at ADHD scores and the usual side effect monitoring, including vital sign changes and also some pharmacokinetic results, finding that the ADHD scores decreased notably, no serious or severe adverse effects. And the most frequent ones, not surprisingly, decreased appetite in a third, insomnia and GI complaints, a Tmax of 4 hours and a half-life of 7 to 8.5 hours. Notably, the pulse and blood pressure changes were not cohesive with what we usually expect from findings in older children or adults. That was attributed really to small sample size and some issues with obtaining the vital signs from these little arms, but something to pay attention to. Small sample size, open label study, but shows us safety and tolerability generally consistent with findings in older youth, and also giving us some information about starting doses, 5 milligrams, and up to doses of 30 milligrams, supported with some limited safety data. We can await the publication of the placebo-controlled trial, which has been concluded, just data not available yet. The other study of relevance is the MPH-MLR, or the Abtensio XR study. Now, this one included an open label dose optimization and then a double-blind placebo-controlled randomized trial on the optimized dose. Largest sample size, N 119 for the optimization and 90 for the controlled trial. And in the dose optimization, we see reported doses starting at 10 milligram up to optimization at 40. The randomized trial was only 2 weeks long, the usual outcomes that we would expect, and finding efficacy for use of the medication. The mean optimized dose was 30 milligrams per day, which for average weight at that age translates into 1.5 milligram per kilogram per day. We're interested in that. And again, no serious or severe TAEs, but note that 80% had mild to moderate adverse events in the open label. And again, decreased appetite, insomnia, weight loss, irritability. So we can conclude from this that in an open label study, safety tolerability generally consistent with finding in older youth, a starting dose of 10 milligrams supported, and the optimized doses were higher than what we heard from the PAT study and what we currently have in our guidelines, as I said, translating to 1.5 milligrams per kilogram per day. We're awaiting the publication of their maintenance study. There's an open label maintenance study that's going to be ready to publish soon. In the pipeline, we're interested in the pipeline to give us an idea of what's forthcoming, what will be available to us by our next review cycle. There was an interesting review by Weigel et al., that also listed trials in the clinicaltrials.gov. When I updated that, it's basically, it lists 5 trials that are really old and not published, so likely not forthcoming on methylphenidate, clonidine, atomoxetine. Then there are 2 that have their enrollment closed, but they're not published, so we can anticipate to get some new findings on a comparison of methylphenidate and parent training in a double-blind placebo-controlled trial, and also an amphetamine ER trial in youth with ASD and ADHD. Then we have the 2 current trials with enrollments closed where publications have started that I have shared a couple of them with you, and others from that sequence are going to be forthcoming. That's the Vyvanse and Abtensio studies. And then listed but not recruiting yet is the important preschool study with viloxazine, and a little bit more about that later. So we have a pipeline. We also are interested in kind of what's going on in the field, practice patterns that may raise concerns. So pharmacoepidemiology and electronic health record studies inform us. They have limitations. They tend to be state level Medicaid data or EHR data, and they also tend to be older, but still relevant. So if, for example, the 2012 to 2016 Kentucky Medicaid claims analysis showed that of 1.2% of less than 6-year-olds diagnosed with ADHD there, 38% were on stimulants, and notably foster children had a 4-fold increased ADHD diagnosis and treatment rate. Panter described in a 2012 Oregon Medicaid claim data what the concerns were for prescribing patterns for 3 to 5-year-olds, and they were prescription 91% was off-label, 40% was alpha-2 agonist use, clonidine IR in particular. Methylphenidate represented 41% with about an even split of immediate release and extended release versions, and amphetamines represented 10%, mostly ER versions. And a more recent EHR observational study of what do pediatricians prescribe also showed initial alpha-2 agonist use in about 35% and stimulants in 65%, with then of course different side effects, but also reported improvements in these observational designs for both treatments. So I think that sets us up for our discussion later. Here are just a couple of points for you to keep in mind. The recommendations for level 1 parenting and classroom interventions are still consistent with strong evidence. We could consider specifying an initial choice of immediate release stimulant rather than jumping right to extended release. And should there be reference to specific extended release stimulants that now there is some beginning evidence base for? Should amphetamines be moved up to level 2? But we right now only have one small open label study available. Also, think about whether atomoxetine should be moved to level 4. Not that there is more adverse new findings for it, but it seems like the amphetamines findings are building up. And then we don't still have anything new on extended release alpha agonists. With that, we're moving on to focusing on those 6 years and older. There, the literature review identified 86 references that were screened, 34 full text records reviewed, of which then 19 are included in the presentation. And you will find that they focus on 4 topic areas. One are the viloxazine studies that are undergirding this newly approved medication. Also findings of newly approved stimulants, a newly published methylphenidate atomoxetine comparison study, and then also findings from a randomized methylphenidate discontinuation trial. Because it represents a newly approved compound for ADHD, I'm providing a little bit more detail on the evidence base and the recommended use of the viloxazine. As you probably know, it was initially approved in the UK and Europe as an antidepressant, characterized as a norepinephrine reuptake inhibitor, now considered more a serotonin norepinephrine modulating agent, and was recently approved for use in ADHD for ages 6 to 17 years, based on a fairly extensive clinical trial evidence. It's marked as Quellbri. The clinical trials were designed as double-blind, placebo-controlled randomized trials and included 2 child and 2 adolescent cohorts where they varied randomized non-flexible dosing, comparing 100, 200, 300, 400, and 600 milligram dosing, and of different length, but in general short, 6 to 8 weeks. The preschool study I mentioned is planned, not recruiting yet, and long-term follow-up studies are underway, but have not been reported yet. So the child studies showed that this compound improved ADHD scores compared to placebo at doses of 100 and 200 milligrams a day. For adolescents, the compound improved compared to placebo for doses of 200 and 400 milligrams a day. And adolescents also were tested on a high dose regimen that did not support the use of a 600 milligram a day in a 7-week trial. So we then have Quellbri indicated for youth 6 to 17 years in doses up to 400 milligrams. The guidance says to start the 6 to 11-year-olds at 100 milligrams a day, titrate in 100 milligram steps, whereas the 12 to 17-year-olds start them in 200 and may even titrate in 200 milligram steps. That's quite a bit easier than what we are doing with atomoxetine. The black box warning does have a warning about higher rates of suicidal ideation and behaviors in clinical studies that needs to be monitored, and also advises that prior to treatment, we need to screen for a personal and family history of suicide, bipolar, and assess heart rate and blood pressure. It does spell out relevant potential drug interactions for this compound and cautions about suicidal behavior, blood pressure pulse increases, activation of mania, hypomania, somnolence, and fatigue. Notably, there were no effects on QT or PR interval or QRS duration in healthy volunteers. So with that brief recap on Quellbri, the 3 new stimulant clinical trials are novel stimulants approved for ADHD in youth. The Asteris is, so to speak, the Vyvanse study for Focalin has serdexmethylphenidate, the prodrug, and dexmethylphenidate. It's FDA approved for patients 6 years and older, comes in 3 capsule strengths with kind of complicated numbers, but equivalent to the dexmethylphenidate of 20, 30, and 40 milligrams. This has a duration of up to 12 hours. Interestingly, a starting dose is recommended the same for all age groups, this 39.2-7.8, and then we're encouraged to up or down titrate as needed. There are serious AE cautions, including priapism, circulation problems, and slowed growth. And we have published data on what undergirds this approval here. Then there is the Adhansia clinical trial. This is methylphenidate beads of immediate and slow release, methylphenidate in 6 capsule strengths with a rapid onset and a really long duration, up to 16 hours, starting doses of 25 milligrams and up to 85 in youth. This was studied in analog classroom designs in children and also in adolescents. For the adolescents, there was also a 6-month open label extension that paid particular attention to self-reported sleep problems, and they report no differences in self-reported sleep outcomes in adolescents. And then we also have the MIDAEUS trials. So this is mixed salts of amphetamine in immediate release and two types of delayed release, one releasing at a pH of 5.5 and one at a pH of 7.0. It's FDA approved for patients 13 years and older. So it is not approved for those younger than 13 years. They had a higher plasma exposure and also higher rates of AEs in the clinical trials. This is also a mega long-acting stimulant, duration of action up to 16 hours. So this was tested in a age group that included the 6 to 12-year-olds and is reported, interestingly, they didn't pull out the separate findings for the age group that this now was not FDA approved for. They followed this up with an adolescent study, a 3-period, 3-treatment crossover study that was comparing 25 and 50 milligram doses with placebo and also an immediate version in adolescents. That's where we see that it's not as fast onset. It differentiated from placebo after 2 hours and then up to 16 hours post-dose, with safety and tolerability comparable to previous reports. We will always hear increases in insomnia, decreased appetite, and here also headaches were common and highest during the highest dose exposure. There was an effort to see whether lower doses might work for the younger population. So they had a low dose trial of 6.25 milligrams, and that failed to show superiority. So definitely it is a 13 years and older medication. This would now bring us to a look at findings from the methylphenidate discontinuation trial, which can also inform our decisions about including some guidance about periodic assessment of continued benefits. So this was work done in 2 Dutch outpatient centers that enrolled 104 youth with ADHD that had been treated continuously with methylphenidate. And then they converted them to methylphenidate delivered via Concerta, basically 36 or 54 milligrams per day. And then they were randomized to a 7-week either continuation of their optimal dose or a 3-week taper and 4-week placebo period. And then they looked at outcomes from rated by investigators, teachers, youth, and parents, looking at various domains. Now, in a nutshell, the investigator and teacher rated ADHD symptoms show that when randomized to placebo, you had a more significant increase. You had a more, I'm sorry, it should be an increase in the placebo because they worsened after the placebo with age moderation because the younger children had worse deterioration than the adolescents. The CGI, the clinician ratings, also showed this quite clearly, where 40% worsened on the placebo arm and 16% on the continuation group. The parent, youth, and teacher rated outcomes show that for ADHD and ODD ratings, we have more worsening when the kids were placed on placebo, no difference in youth self-ratings, and also no group difference in quality of life and parenting stress, and also no difference in AEs by groups. So we basically can conclude that continued methylphenidate remained effective for core ADHD and ODD symptoms after long-term use. The discontinuation didn't impact other comorbid problems, quality of life, or parenting stress. So some patients may be withdrawn from long-term methylphenidate regimens without deterioration. So periodically, we should assess continued treatment and need benefit. I mentioned that There was a recent publication on a comparison of methylphenidate atomoxetine. I'll briefly share relevant findings. This was work that was conducted in Taiwan, and it was conducted a few years ago. It's just getting published now. Data collection occurred in 2009 to 2012, and it's also part of an overlay there where genetic data will be analyzed and published. What we have here is an open label head-to-head randomized clinical trial of oral methylphenidate against amoxicillin, MPH up to 54 and amoxicillin up to 1.2 milligram per kilogram per day in 7 to 16-year-olds with ADHD that were drug naive and followed for a 6-month period with outcome ratings, with high quality outcome measures in variable domains, finding that for emotion and behavioral outcomes, there were improvements in both groups for all informant types. By 6 months, the methylphenidate outperformed atomoxetine for aggressive behavior, for somatic complaints, and also for conduct problems. This is even by youth self-report. There were improvements in social adjustment in both groups with no group differences, and on the neurocognitive functioning, also improvement in both groups, and some differential better improvement for methylphenidate for response selection and inhibition. So this study obviously has limitations because it's open label randomization, but some of the raters were definitely blinded. The other thing is they didn't really bring methylphenidate up to the doses that we might normally use. It was only up to 1 milligram per kilogram per day, whereas the atomoxetine was reaching more the doses that we might use to maximize. They also had dropout, but they used really good diagnostic procedures and a great multi-informant design, well-validated measures. So I thought it was worth keeping that in mind, and as we consider our current levels for methylphenidate, which is level 1, and atomoxetine, which is level 2. Then lastly, the literature review identified these new studies on stimulants and growth impacts, one in a really important intervention study and the other a large-scale observational study. So the Waxmonsky et al. Is the intervention study where they followed for 30 months 230 youth ages 5 to 12 with ADHD, and they did a double randomization, first randomizing them to receive either stimulant or a small number, 22% behavior treatment, and then subsequently randomized those who experienced BMI decline of more than 0.5 Z units to one of 3 weight recovery strategies or weight recovery treatments, WRTs, namely monthly monitoring of heightened weight, but continuation of your daily meds, drug holidays with meds limited to school days, and caloric supplementation with 150 calorie supplement drink and continuation of daily medicines. Those were the intended intervention arms here. A nice picture of what their double randomization looked like. And then the results are that prior to initiating these weight recovery strategies, medication use was associated with significant reductions in weight, height, and BMI scores. And then for those who needed the recovery strategies, the magnitude was over 30 months, 2.4 kilograms and 1.3 centimeter less than expected values. Now, when this was looked at in the intent to treat analysis, all 3 interventions increased weight. The monitoring by an average of 1.8, the drug holidays 3.4, and the caloric supplementation 3.0, but there were no effects on the height velocity, even though they could recover weight. Now, they also did a per protocol analysis that showed larger weight effects for the drug holidays and the caloric supplementation than just the monitoring. That was in part because parents were escaping their assignment and they were doing things that made sense to them. So I think these findings, they have definite implications for us. And Waxmonsky also tried to see if there were any predictors that would give us clues for who's at risk for what when we prescribe stimulants. And they found that percent days medicated and total medication exposure was the most consistent change predictor for all three outcomes. Also, importantly, that kids that started with lower Z height and weight experienced larger C BMI and Z weight decreases in the first 6 months on the meds, so more vulnerable than their taller and heavier peers. Greater appetite suppression predicted weight and height decreases, whereas behavioral symptoms did not. And Z weight and height correlated, but as we also heard, unfortunately, weight restoration did not improve height velocity restoration. And then in the observational study conducted by Banaszewski et al., a large 2-year observational study of Vyvanse in 10 European countries, 35 sites, found that weight loss was a self-reported adverse event in 20% of the participant, 16% of the child, and 27% of the adolescent participants. The decrease in Z-scores for weight, height, and body mass happened over the first 36 weeks and then seemed to stabilize at a reduced level. They also assessed Tanner, most remained at baseline or shifted higher. And together, the observational and the intervention findings definitely support emphasis on regular monitoring of growth and development in children receiving stimulants. Considering other interventions, to round off our deliberations here, there are 2 FDA-approved medical devices. They were approved through a de novo regulatory path for low to moderate risk type. That's the external trigeminal nerve stimulation system, or the Monarch ETNS, came out April 2019. And then video game therapy, the Endeavor RX, came out June 2020. And also briefly, we should revisit stance on omega-3 polyunsaturated fatty acids. The Monarch ETNS system was approved based on a 4-week placebo-controlled efficacy study in just 62 children with outcomes in the area of ADHD symptom ratings. They included kids with primarily inattentive or combined subtype, ages 7 to 12, and those were children who could not be concurrently taking medications. This device has to be worn at home overnight and takes up to 4 weeks to produce noticeable results. The AEs reported are drowsiness, increased appetite, trouble sleeping, teeth clenching, headaches, and fatigue. There is an issue with insurance coverage for prescriptions. Reportedly, starter kits cost $980 and cover 4-week supplies, and then refill patches come at $10 a piece. In the APA review, they reference this very briefly and say, current evidence is sparse and therefore cannot be recommended without more study on efficacy and safety. The Endeavor game came out after the AAP guidelines came out. This approval was based on review of data from over 600 children, outcomes in the area of attention, including TOVA assessment, academic and parental ratings. This was done for kids 8 to 12, again, with primarily inattentive or combined subtype. Now here, this is intended for use in therapy programs, along with medications therapy and or educational programs. So it is not standalone or a substitute. The side effects of a video game here listed as frustration. This intentionally gets more demanding for the children, headache, dizziness, emotional reactions, aggression. One is supposed to play 25 minutes a day, 5 days a week for 4 weeks, then have a follow-up and determine next steps. An initial prescription is for 3 months. The insurance coverage for prescription is again an issue. Reportedly, the price for a 90-day prescription is $450, and if it's paid out of pocket, $295. And then I mentioned, I thought omega-3 fatty acids are relevant to look at. Again, we have variable conclusions to date. There are the 2019 AAP guidelines, which don't specifically address this. They make generic comments on diet as non-medication treatment with too little benefit or little to no benefit. And then looking at the National Center for Complementary and Integrative Medicine, they still issue that despite a lot of research, it's unclear whether taking omega-3 fatty acids is helpful for ADHD. And in the World Federation, which offers the nuggets, not so much recommendations, they identify meta-analyses reporting very small to medium improvement in ADHD symptoms, no effects on emotional ability or ODD symptoms. Now, despite these ambiguities, families and clinicians select this. There is variability in dosages and ratios of over-the-counter omega-3 in formulations. And of course, the prescription strength has the indication for hypertriglyceridemia and is for adults only. So I think that gives us some thoughts here. And again, to kick us off for the discussion, potential discussion points here, we don't have new medication classes. We have the one new SNMA, viloxazine, several new extra long-acting stimulants, a comparative effectiveness study, MPH-ATX, that doesn't seem to suggest implications to change guideline treatment levels. We will need to update our medication section to include viloxazine and the new stimulant options. And then we can consider whether to relax dosing guidance for the immediate release and clonidine and guanfacine, which is quite restrictive. The FDA guidance for ADHD off-label use is unchanged. For TIC or ASD treatment, there are higher max dosing ranges offered, like clonidine up to 0.4 milligrams per day for 5 years and older, and guanfacine 4 milligrams per day for 7 years and older. And we could also address the co-prescribing with some suggestions. The growth impact studies suggest we definitely want to emphasize the need for consistent monitoring of height, weight, appetite, and BMI. And then there are some suggestions for adding an additional consideration box that refers to these optional treatments, including with FDA-approved devices and or the omega-3 fatty acids. With that, I thank you for listening for this speedy presentations. The slides, including the reference information, will be made available. And so next, we're going to be moving on to the panel discussion of revisions and updates to the ADHD section led by Dave Castellanos. Thank you.